now we shift gears to these emerging products that, could be a couple of years, maybe even longer away, but Elora NAB.
Sure. Elora NAB is an interesting product starting phase 2 in IBS soon. It's a timely product because it's a cannabinoid receptor agonist, and it's a CB2, affects the CB2 receptor, so it doesn't have any of those psychoactive properties. What's interesting about the product that it seems to reduce pain, particularly in the host that is sensitized. So for example, someone like with inflammatory bowel disease, and they can have pain even though their inflammation is reduced, that it seems to be effective. And we know that IBS, there's evidence for visceral hypersensitivity in at least a subset of patients. So it has promise, and I think we'll have to see what the data shows, of course.
To me, it's a really interesting concept. We've been looking for a visceral analgesic for a long time. I still don't think we quite have one. We've talked about a lot of medicines today that affect different aspects of abdominal pain, but this is maybe a new mechanism that could augment others, or may unto itself be an effective visceral analgesic. But we need more data to find out.
Okay, Bill, tenapanor. We've heard a lot about tenapanor. Phase 3 is done. Mm-hmm. What's happening?
Mm-hmm. Well, the phase 3 is completed, like you said. There's been discussion about submitting a new drug application. And so for people who aren't familiar with the drug, it's an NHE3 antagonist. So it blocks the reuptake of sodium from the small intestine, and in that way can help with constipation-related symptoms.
Another moisturizer?
Yeah, but by a different mechanism, but absolutely a moisturizer, yeah.
But a lot of enthusiasm around that product, and perhaps it was because of a different mechanism. Maybe some people, as Dr. Razai points out, respond to one mechanistic action of secretagogue, and maybe this was another mechanistic action. But we haven't heard a lot about what's going on with the FDA yet, but maybe soon.
We'll see. I think I'm cautiously optimistic. We'll see how the application, when it gets submitted and how it proceeds.
Perfect. And Dr. Razai, let's talk about the last thing on our list is Sinton, which is in phase 2 trials now.
Yes, so we talked about methanogens being involved in IBS constipation. So essentially by production of methane themselves, that they can slow down the gut motility. We knew from studies in the past that statins can reduce the methanogenesis in these type of archaea. So Sinton is a non-absorbable statin that suppresses methanogenesis in this archaea and potentially can improve constipation by the direct effect on the microbiome, which is interesting. This is another microbiome modulating drug in the field of IBS, which is this is quite exciting now that we're putting all together. We're finding different mechanisms of action that we're putting into work to help IBS patients that by themselves or even in combination hopefully will help patients.
Maybe even a precision medicine play in the sense that you have a biomarker that
Absolutely.
Cultivates the population that could benefit. So that's kind of an interesting thing. So now we're in our final question, and I think this is for the entire panel. What advice do you give to the community physicians treating IBS? Well, let's just go across the board here, because when you're talking to not the gastroenterologist, but the doc in the community in the trenches, give them some hope on IBS and give them some light that we're trying to rule in IBS now, and to have confidence in their abilities to diagnose this. So let's start with Dr. Razai and move across.
I think the biggest thing is that our understanding of irritable bowel syndrome in the last 20 years has been revolutionized. As we talked about dysmotility, as we talked about microbiome, the role of diet, different therapeutic targets that we have, it has completely changed. And we should be aware of that, and we should promote awareness towards patients as well, because there's still that stigma out there that for IBS patients there's not much to do for IBS, and that's not true. There are multiple treatments that are available that we can help these patients moving along. I think that's the main message in this day and age that has changed in the last several years.
Yeah, and I agree with that as well. I mean, this idea of this stigma persists, and it's time to end that. It's like that's the first thing I would say is, you know, I think many of us were trained to think of IBS as a psychological condition that, you know, is maybe not as serious or real or objective as something like IBD. And we talked about that earlier. And it's time to fix that problem first and foremost. And you mentioned this earlier, Mark. Take your patients seriously, listen to what they have to say, and recognize that we now have this growing menu of options. And although it might sound like alphabet soup, plecanatide and prucalopride and all these different treatments we've discussed, the viewers don't need to be an expert in every single one of these treatments, but to know that they exist, to maybe become comfortable with some of them, and to know that there are gastroenterologists who can help them manage these patients proactively and meaningfully. I think that's really time to make that switch.
Right, Tony?
Yeah, and
Anything left? These guys were
No,
hogging the answer.
I agree, and I think, as we've said, making a diagnosis early, confidently. We have lots of data to suggest that we don't need to do extensive testing. We can even now rule in IBS, but you really need to make that diagnosis early, avoid all these unnecessary tests and procedures, and then start treating your patients. And we've talked about starting at the beginning, doing the lifestyle, the diet. There's lots of evidence with diet, and there's even evidence with exercise and stress management. Start treating your patients. Those with mild symptoms, oftentimes that's all they need, and then you progress up quickly to treatments. And we start with over-the-counter, depending on their bowel function, and then move into prescription treatments. And we didn't talk a lot about psychological therapies, but patients with a lot of comorbid conditions, particularly those with other chronic pain syndromes. These are often the most difficult patients to take. We will add that very quickly in the treatment. They may need to be referred to a GI or a specialty center, but do that quickly with your patients, and I think you can really help them.
I've really been struck by how this whole field has evolved so quickly. I mean, we've talked a lot about the evolving pathophysiology and the various treatment options, but I think from a very practical standpoint, the thing that's really struck me is how IBS, for me personally, has moved from being perceived as one of the most difficult things that I can confront in clinic to being one of the most easy things that I confront in clinic now. I actually love seeing IBS patients because I have a full suite of different things that I can offer them. And I think that thinking more integratively and holistically and understanding what your options are makes this a very treatable group of individuals. And by the way, I recognize that in primary care, you may not have all these bells and whistles. That's okay. Incorporate the ones that are practical for you and your staff and the resources that you have, but understand and utilize practices that have embraced this integrative, holistic approach, because those are the ones that are going to lead to the best outcomes for your patients.
Well, thank you, everybody. I feel honored to have worked with you today because you've really provided great insights and respect all of your opinions. This is the leadership in this field, and I'm glad that they were here. Thank you all for your contribution to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be helpful and informative.